Wide anterior thoracic corrects for rotation fixations in the thoracic spine from about T3 to probably T9, T10, but really if you modified it, you could do this from any part of the rib, So just to remind you of the motion palpation that would lead you to this particular adjustment. Can I have somebody to help me out with this?
Oh, I understand.
Yeah. Ryan, come and sit and face this wall. So just to remind you, cross your arms for me. You stand contralateral to the side that you are testing. You put your thumb on the non-articulating tubercles. You get in close. You rotate your patient toward you. What should happen is, as you rotate your patient toward you, the rib should translate anteriorly, and so the non-articulating tubercle should go anterior, and therefore you should have a diminished sensation underneath your finger. There comes a point where you might feel an increase of pressure on your finger. So you can either set up for this like a modified cross bilateral, right, with the patient prone. Okay. You can set up for it with, so get that on your tummy. You can set up for it like a modified cross bilateral with the patient prone. You can set up for it, you okay there? You can set up for it as an iliocostal technique, or you can set up for it like this, like an anterior thoracic. You can come sit up for a sec. You're going to lie on your back. In a modified anterior thoracic, the difference is we're no longer on the spine, we're no longer on the midline. And we're not using the flat surface of our hands to jimmy open the spinous processes like we did before. Instead, what we have is a non-articulating tubercle that is now facing the floor that we got to bring back this way. What we're going to do is we're going to adduct our hands and we're going to use the thenar eminence as a pillow to stick underneath the non-articulating tubercle. And you can do this either ipsilateral or contralateral. So you're going to make your patient cross their arms like this, or Dr. Duck likes it this way. It doesn't really matter. You're going to bend your knees for me. You don't have to bend your knees, but always to help with flexion, bending the knees, keeping the headrest elevated, you're already inducing a little bit of flexion. It helps with this adjustment. Okay, the problem is on this side. So I can set up for it contralaterally. So thenar eminence is going to go onto the non-articulating tubercle of the rib, and I'm going to set up for it like this. Or I can do it ipsilaterally. So if you have a large patient you can't reach across, you can always set it up like this. Doesn't matter. I like contralateral for Ryan, so that's what I'm going to do. So thenar eminence is going to go on the non-articulating tubercle. That is out of place. Here. Okay. Now, he's going to breathe in and breathe out. In this case, the breath is to assist me in taking out joint slack. So always in the thoracic spine, breath is essential, whereas in the lumbar spine it is optional, depending on what you're trying to do. Here it is essential. So the idea is I'm going to be pushing the non-articulating tubercle anterior using his body weight and my body weight. I might, depending on where I am in the thoracic spine, need some degree of cephalad traction. I'm definitely going to need flexion. No matter what I need, I want to feel maximum weight on that thenar eminence as that non-articulating tubercle is pushing into that thenar eminence. I want to feel maximum weight. If I feel only a little bit of weight, it's not good enough. If I feel no weight, I'm not doing anything. Okay? Maximum weight. If I need cephalad traction, my thrust is going to be A to P, but it has a slightly cephalad thrust to it. And if I'm lower down in the thoracic spine where I'm at T8, T9, I'm probably just going to have pure A to P. So depending on what I needed, I'll either have about 45 degrees or I'll have 90 degrees of the thrust. Okay, so you're going to breathe in. On the breath out, I'm going to induce flexion. You're going to breathe breathe regularly. I'm going to induce flexion and plant my sternum onto the elbows like I did for the anterior thoracic. I'm going to roll my patient over, and I don't feel a lot of weight on my thenar eminence, so now I'm going to induce a little bit of cephalad traction. So what I did was a U. I did a U. I did a U shape. And then I'm going to do the thrust. Okay, breath in, all the way out, U shape, thrust. You okay? Okay, can we have somebody show Ryan how to do this? Sit. Sit. Yeah, I need to see. Cross your arms. Hurt? Hurt? Yep. Okay, make either side. Come and lie down on your back. Okay. Set me up.
Have her cross her arms.
Cross your arms. No, cross your arms the way everybody crosses their arms. Do you like that?
No.
I'll cross your arms. You're going to cross your arms. And you're going to hug your shoulder blades. You always want to make sure you have a nice V, not a flippy, floppy X. Okay? Hugging the scapula, not hugging the shoulders. Okay, next.
Rotate her towards you.
I can rotate her towards me. If I was doing an ipsilateral adjustment, I would actually rotate her away and find the non-articulating tubercle and set up like this. But I can also set up for it like this. Okay, I rotate her towards me and I find the non-articulating tubercle, and there it is, and?
Put your thenar eminence on it.
Okay, I'm going to put my
Or
thenar under it.
Yeah.
Okay.
Okay. Then push your other hand on her elbows. Yeah. And then you're going to, I guess, move your, as she exhales, you're going to move your body so that your sternum is over the contact point.
First I'm going to flex her arms.
Oh, sorry, yeah.
First I'm going to flex her arms down and plant my sternum over it.
Okay.
And then
As she exhales, you do the U.
I'll be doing the U as she exhales, until you feel maximum weight under the thenar eminence, and then
drop.
do the drop. Okay. Breath in, all the way out. Lovely. You know what? For rib adjustments, this one is actually the gentlest. This is nice and gentle. Super nice, super gentle. Okay, so for the rest of the time, you're going to practice modified anterior thoracic, and then you are going to show me what you would like to remember from days long gone. Okay?